Right. Good morning, everyone. And thank you very much to Dr. Manpreet for including me in this IC. It's an absolute pleasure. So I'm going to be talking about deep anterior lamellar keratoplasty, and we'll be focusing more on what possible hurdles that we could have. So there is no doubting as to why we would prefer doing a lamellar keratoplasty. It definitely has a lot of advantages. However, it does have a slightly steeper learning curve than a full thickness penetrating keratoplasty. And the idea with DALK is, it's extremely logical as a surgery. And if you just understand the air dynamics, then it makes our lives much easier in trying to tackle these complications. So decision making is to look at the scar, and this is very, very important because you have to decide what technique of DALK you would do. And if you have a full thickness scar secondary to a high drops, not anything else, but secondary to a high drops, then you would definitely avoid doing a big bubble technique because you can have a break in the DM at that stage. And believe me, a very well done manual dissection will also give you very, very good results. It may be slightly slower in recovery, but the patient will definitely do well, and it's much better than converting to a full thickness keratoplasty. So understanding the scar and depth of scar is very, very important. And just because you have a high drops does not mean, a post high drop scar does not mean that you'd have to directly go to a penetrating keratoplasty. You can still get away with doing a DALK. So this is a routine big bubble DALK surgery. I've already de-roofed and removed part of the anterior lamella. This was a very thin cornea, so I've left the cap at the thinnest part. And in this thing you see, we've just gone to a deeper level, put in the cannula, put in air, formed the big bubble, de-roofed it, and now we are doing the usual quadrant technique to try and remove. The only instrument which I think is absolutely very, very useful is a blunt tip scissors, so please make sure you invest in that. It's not at all expensive, but it does make our life very, very, much less stressful when we are doing the posterior dissection and very close to the DM endothelium complex. So at this point, one very important thing to remember is when we are using, irrespective of whether you're using a needle to make the big bubble or a cannula, you have to understand the location and the depth and the direction. Now, initially, it's a little difficult to assess the depth, especially with the needle, and the fear is always that we will be too superficial, and I'll be coming to how we can understand it. In releasing the bubble, there is our own set of challenges that we will face, and of course, the posterior dissection of the stroma. So let's deal with that subsequently. For a manual dissection, if you have to do the same step, you de-roof anteriorly and then go ahead. There are multiple techniques described, whether it's the groove and peel or directly go to a different level. But basically, it's the same thing. You just keep removing layers of stroma till you reach deep enough. And as you go posteriorly and closer to the DM, you'll find that it's almost like you can peel off the stroma, and that's your clue that you are very deep and need to be more careful. So the main point is that if you understand a few things about the surgery, it's easy to avoid complications. So one of the most simple, and this I can't really call a complication it's more of a hurdle, is that you just don't get the bubble at all and keep injecting into the stroma, and finally this happens where you want the air to go forwards. Stromal emphysema, or the bubble will come only if it's going forwards. If it's coming backwards, stop. And also, if you're having stromal emphysema, stop, because if you keep injecting, it will just become a diffuse entry. Last few things. One is, if you think, you see air entering into the AC like this, and please understand that if it is coming in from the side, you see the bubbles entering in from the side, that is not a perforation. That is the air which has traveled around and come in through the trabecular meshwork. If it's coming right centrally, you see air in the AC where your needle is, that's a minor perforation. You can also get a lot of post-operative complications, even though rejection is very, very low. But there are a few things that can happen post-operatively, usually well handled. And I still say that wherever possible, please go ahead and do a lamellar keratoplasty. Thank you very much.
Thank you, Dr. Sharon. It was an excellent